Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramm. Marcus at Home welcomes Professor Justin Ezekowitz in Edminton, Alberta, with whom we would like to discuss the issue of salt intake in patients with heart failure, focusing upon his landmark sodium HF study. Justin, it's an honor and a pleasure for us to have you this Canadian morning, this European afternoon. Thanks for being with us.
Thank you for having me on this. It's a topic that I like talking about, and great to hear and be here on your podcast.
So Dr. Ezekowitz is a cardiologist. He is professor at the Department of Medicine at the University of Alberta, Faculty of Medicine and Dentistry. He contributed to many pivotal studies in the field of cardiovascular disease, particularly heart failure, to name just two of them, Aristotle and Victoria, among many others. He wrote national, Canadian, and international guidelines on heart failure. And now he addressed one particularly difficult area of heart failure management, namely the issue of lifestyle interventions, particularly reductions of sodium intake in heart failure patients, by initiating the sodium HF study, whose results he has recently presented at the American College of Cardiology meeting and published in parallel in Lancet. My co-moderators are Dr. Martin Brzoska from Frankfurt, Germany, who is a nephrologist and advocate of a low salt and low fluid intake strategy for most cardiorenal patients. And both Martin Brzoska and I are very happy to have Professor Luís Beck-da-Silva Neto from Porto Alegre in Brazil as second co-moderator, as Professor Beck-da-Silva has also done some years ago a randomized controlled trial on salt intake in acute heart failure patients that has been published in JAMA Internal Medicine. So this is our first tri-continental talk, and the first time that we have both the principal investigator of a landmark study and the author of the study's accompanying editorial, as Professor Beck-da-Silva wrote the editorial in the Lancet to the sodium HF study. So this is the second time that we address the issue of sodium intake in cardiovascular disease. We had some months ago Professor Neil from Sydney, who discussed his SARS trial on salt substitution in patients with hypertension. And this study clearly showed that by substituting potassium chloride for sodium chloride, one can lower the number of strokes and of all-cause death in patients with hypertension at high risk for atherosclerotic disease. Now, we all know that sodium intake is far too high in many patients around the world. And when it comes to heart failure rather than to hypertension, it gets more difficult because we have some guidelines that are rather weak in their statement, which suggest to lower sodium intake in heart failure patients, but the evidence so far has been rather weak. And this is actually the background for sodium HF. I would be very happy, Justin, if you share the ideas for doing the study and then go through the methods and the main results with us.
Absolutely, and that's a great introduction. As Dr. Neil's SAS study was instrumental, 600 villages, 20,000 patients, and showing a reduction with just a small 25% reduction in the sodium component of the salt component. So for sodium HF, it really came from a clinical question, which was, does reducing or advising patients to reduce the amount of sodium in their diet change the clinical outcome? It started with a simple clinical question that we often, when we're in clinic and see patients, we often advise it, but we looked back through the literature and we saw quite a few small studies, really a lot inconclusive, some acute, some chronic, and some by my colleague on the video as well, Dr. Beck-da-Silva. And really, but generally inconclusive, that there was really an addition. So we designed this randomized trial to answer the question in a very pragmatic fashion, to advise for ambulatory patients with heart failure whether or not they should reduce dietary sodium. So we, very straightforward one-to-one randomization. We recruited patients from over 26 sites in 6 countries, and included patients with a broad heart failure. So a pragmatic definition of heart failure identified by the clinician at sites where we'd already selected and kind of knew what they're doing in terms of how to select patients and include them into trials. And they were randomized into one of 2 different arms. The first arm, or the control arm, was that of usual care. no additional advice, just provide the usual things you do in clinical care, which is usually instruments to a clinician like myself saying, you should reduce the amount of salt in your diet. And the other arm, the intervention arm, was included a target of less than 1,500 milligrams of sodium per day, which was followed and helped by dietitians along the way to help them get there. So they were the target overall was less than 1,500 milligrams. And as you can see, in general, we followed people forward for a year. And in fact, we have follow-up going on for 2 and 5 years. But we followed them forward every 3 months with 3-day food records to both assess their dietary sodium intake. But in addition, we also wanted to use that as their counseling tool. We used the intervention was a simple thing, which was a menu-based system rather than a metabolic kitchen making all the meals. We had a menu-based system that we adapted to the 6 countries and local regions within those countries to allow patients to really eat how they normally would in their day-to-day behaviors at home or at a restaurant, and just select things off these very broad menus, just solely targeted on reducing sodium. So we had to keep the calories and potassium and all the other things as equal as we could, as isocaloric as we could. And we followed them forward for the primary outcome of cardiovascular hospitalizations, cardiovascular ER visits, or all-cause mortality as a primary outcome. And then the secondary outcomes were the parts of that composite. But also we assessed KCCQ as well as the 6-minute walk test and the New York Heart Association class going forward over the 12 months of the primary intervention.
So when it comes to the baseline criteria, you already mentioned it was kind of centers experience in treating of heart failure, but there was no baseline echocardiogram mandatory, or did you do echo at baseline?
Yeah, so this was a pragmatic trial. So we did not do echocardiograms at baseline. So instead we captured whatever clinical information was available on the chart regarding this. And interestingly enough, not surprisingly, that most patients have an ejection fraction available within the last 12 to 24 months. If you start looking at large surveys, it's pretty common. So we didn't have trouble getting that information. So we allowed just the capture of that information. And even if you look at our distribution of ejection fractions, the median's around 36%. So we had a mixture of HFrEF and HFpEF built into there, which allowed us to really explore is there a real differential across the outcomes.
Okay, so let's switch then to the results. Firstly, maybe looking in how fast sodium intake was reduced and which effect this reduction had on blood pressure and body weight.
Yeah, so this is one of my favorite figures of the entire trial because when we first started looking at the data, we were worried, and something I've been following all the way through was things like the blood pressure, body weight, and energy intake, the calories. But when you start to look at the sodium intake alone, our patients started off at around 2,200 milligrams per day of sodium intake, and it came down nicely by 6 months and then 12 months in the intervention arm by about 415 milligrams per day, and really relatively unchanged in the usual care arm, which is always the control arm that gets you. That's always the problem in these trials. And that was about a 3% in the control arm and about a 28% reduction in the intervention arm. Really important is that the error bars and there's quite a bit of a spread of people's dietary sodium intake. And so we have lots of work to do to unpack that as secondary analyses. But in general, the difference between groups was close to what we wanted. We were targeting about 500 milligrams difference between groups. We thought that would be kind of optimal, but that was kind of our overall goal. When we looked at body weight and calorie intake, these are kind of almost negative controls for, did people report the information accurately? And it helps us to see that body weight and calorie intake really didn't change too much with our menu-based system. That's kind of always a concern. You change one food for another, you kind of change the calories or something else. The blood pressure one, I'm still uncertain what to make of this versus a normal variability versus it's a real signal or not. It's not statistically significant, and even numerically, it's hard to tease it out. But visually, it certainly looks like those small differences of 1 or 2 millimeters of mercury at the first 3 or 6 months. Are they real or not? But by 9 or 12 months, it's really come back to neutral, not statistically significant, but important, visual observation.
So let's switch then to the major endpoints. The primary endpoint was a composite endpoint, actually.
Yeah, the composite endpoint was not statistically significantly different, and I'm very conservative in the interpretation of a clinical trial. We powered the clinical trial. Here's our hazard ratio, not significant, but numerically lower in the low sodium arm compared to usual care with a hazard ratio of 0.89, but very broad confidence interval. So I couldn't say with confidence that they were just squeaked by. We did not. And then we broke it down into the secondary endpoints. The all-cause mortality, it looks like there was a greater number of events in the low sodium arm. This is a difference of 5 deaths overall over a year. So really, I think visually it looks like there's a difference, but in fact, it's not statistically significant, and it's a 5-death difference over a year. It's very difficult to say that that's useful. And then we broke it down into our further components as individuals can look on the table. But also just, it's really, we expect, one thing, Gunnar, is we expected that the ER visits to be higher in number, like numerically higher number of ER visits based on clinical practice, but we didn't have that many cardiovascular ER visits. We adjudicated all of these, but there were lots of events, but none of them were cardiovascular, even with a very kind of a broader net of cardiovascular.
Might this have been affected by the COVID pandemic?
We did have some issues around the COVID pandemic because obviously the last 2 years of the trial really impacted by that, both in the recruitment, the intervention, and then the outcomes. And we did track the COVID related ER visits and COVID other issues. I'm uncertain as to their impact. I think there was certainly fewer events in the latter year, the last year of the trial, and that's not unexpected. With other trials, we've seen the same thing. That said, our patients are highly susceptible to negative outcomes or poor outcomes. So if they were going to have exposure and poor outcomes, I would have expected to show up perhaps in the hospitalizations. And we have a bit more data to unpack there. And Dr. Beck-da-Silva did outline a couple of the things, even in this nice editorial where, well, how did that impact? And so it's important to look at that.
So then let's look at some subgroup analysis. I think the results are actually valid across all patient subgroups, if I got it right.
Yeah, absolutely. The one interaction we saw was that it looked like a low sodium intake was better in the under 65 age group. I'm really uncertain as to what to make of that, as subgroups should be looked at very cautiously. And so we'll have some more additional work to do. This is difficult to know if this is a real signal or just an indicator. We need to look for this. So what we have some secondary analyses ongoing that look at a lot of these factors. And some additional things were pointed out by the reviewers, which we also conducted, which were post hoc subgroups, which included things such as renin-angiotensin blockers, geography. We've done some site variability, and really didn't show any difference across those subgroups. And I think that was an important question was unanswered as to whether people on an ACE or ARB might do better or worse because of the lower sodium diet or not.
And then let's switch to some other very important analysis that you did in this study, mainly on quality of life, on walking.
Yeah, so this was, I think the most striking was we did, all the 3 KCCQ scores, and really when we think about the overall summary score, the clinical summary score, the physical limitation score, all showed a significant, statistically significant and numerically significant difference favoring lower sodium, the lower sodium arm, which really highlighted that patients in the low sodium diet potentially had a greater or higher quality of life compared to usual care. And this is a pretty robust set of data, given not only the numerical values of 3 to 3.5 points, but also the p-values were significant. Where it differs is the 6-minute walk test. We had a real tricky time getting the remainder of the 6-minute walk test done, because those have to be in person. And as you can imagine, we can do quality of life over the phone, but you can't do a 6-minute walk test easily over the phone. And we hadn't validated the other methods. So we really had a huge drop off. So what was an early signal of looking like there was an improvement in 6-minute walk test just didn't carry forward to the end. So not statistically different. The NYHA class really correlates with what we saw in the KCCQ. The patients in the low sodium diet were more likely to improve at least one NYHA class. We've looked at this a number of different ways, but they're more likely to improve at least one NYHA class over the life of the trial if they're in the low sodium diet. So the clinician perception, they were doing better. The patient perception, they were doing better. kind of do correlate there. I was really upset that we didn't get as many 6-minute walk tests as we wanted, because that would really add another functional piece to this puzzle.
So maybe my last question before switching the microphone then to my co-moderators: and how far did these results now affect your clinical practice? And how far did you change or did you not change dietary recommendations for your heart failure patients?
Yeah, so this is a great question, because now I'm like, it's not a clear win or a clear loss. Like it's so I think what I've done is taken a bit of a more reserved approach, which is, if I'm recommending it to an individual, a patient, it's for the benefit of quality of life, so their overall symptomatology. And I say that cautiously, knowing it's a secondary outcome, and all the warts go with a clinical trial of that nature. But I'm less dogmatic about it. And I think that's really important for us to just take a step back and say, is it all patients who should be reducing their dietary sodium intake? Is it most patients? And then for what goal? And so we do need to move away from what I think is called the shame and blame of patients, where they had one bag of chips and they feel terrible. We go ahead and blame them, and then we get the cycle, which is not good for their overall health. So I still recommend it, but I take a bit more of a step back and how we are cautious and interact with our patients.
Okay, so let me thank you again for your study. And as you heard before, I'm always advocating low sodium intake when treating edema and cardiac failure on our ward here in Frankfurt. And what hit me in the first place when reading your study was that the standard care group had, for my perception, a very low intake of sodium. I myself would calculate the average sodium intake of our patients higher. What we see here is that patients are over the day with their usual diet are eating, let's say, 15 grams of sodium chloride, which would equal about 7 grams or 6.5 grams of sodium. Is that somehow related to cultural preconditions in other countries, or what's the reason for that?
Yeah, so this is one where we've looked at this carefully, and I also remind people that I'm not a dietitian, so just like, any food assessment has got to be cautiously interpreted. But when we started looking and designing the trial, one of the questions was, how do we gather the data on what people are actually eating, salt versus sodium and total amounts? And what we realized, if you look at the scientific data on the food recall, which is just, what did you have over the last 24 hours, it's pretty loud, not terrific. Yeah. Food records are much better. And we also looked at the urinary sodiums, which for patients on a diuretic do not correlate with dietary intake. So we had to step away from doing things like urinary sodiums, where they don't correlate well. When we start to look at the total amount, I challenge people to actually do the formal assessments of 3-day food records or something similar in their patient populations, because when we started to look around, there's a difference between what we assess in our most vulnerable patients, those who are perhaps showing up for dialysis, for the example, and what they're eating, versus the broad population, versus cardiovascular disease patients, versus patients with heart failure. And I actually think we often overestimate how much dietary salt they're taking in for some groups and underestimate for others. So I looked around for really high quality data, and you'd be not surprised that there's not a lot of great high quality data of prospectively collected food records in populations and that we care of, like nephrology based populations with dialysis or heart failure, whatever it might be. And so I accepted in Frankfurt, maybe if that's what they're happening, but I would also want that to be formalized and do that properly, and 100 patients to say, is that accurate or not? Because I'm not saying it's not, but I just wanted to be sure, because then you would have a basis from which you could design an intervention or a strategy for those patients, rather than what we often do, say reduce it, and that doesn't really do much for those patients.
So what you say is that collecting urine and measuring sodium in urine is not an exact form of estimating the eaten sodium in patients?
Yeah, so this is it's a hot topic, and I kind of waded into this indirectly. It was there's been two schools of thought. One is urinary sodium reflects dietary intake, and we can use it for assessing broad populations. And that's probably got some merit, and there's been the InterSalt studies and a lot of studies around that topic. And then there's a school of thought that it really doesn't reflect food intake, so the dietary intake. And there's that camp, which includes Bruce Neal, who you've had on here before, says it's probably not a great measure as much as we think, because they're all formulaic. So they're all back calculations is to try to get a regression equation to predict it. Now, that's all great, but what about our patients we actually see? And so the ones, a really nice study by Joanne Arcand out of University of Toronto, a couple hundred patients with cardiovascular disease and heart failure and non-cardiovascular disease, looking at what's the correlation between diet, like prospectively collected 3-day food records, and urinary sodiums, collecting the 24-hour urines, which is not easy. And it turns out that it's probably, urinary sodium is probably well correlated if they're not on any type of diuretic. But once they're on a diuretic, it's all over the map. And so I think we kind of could get into a bit of a tricky area saying, oh, well, you're eating too much sodium. And they say, well, I'm not. And you say, well, the urinary sodium says this and my food says that. And so I think loop diuretics take that out of the equation.
You showed that you had a certain, sodium intake in the control group and the sodium intake in the interventional group. And I was looking at the error bars which you had. It seemed that they were overlapping. In fact, what I thought is that the actual difference between the interventional group and the standard care group in view of the sodium intake is very low. So the mean, I think it was 1,500 milligrams against 2.2 grams. So, and the error bars were overlapping.
Yeah, so I think that's something we see in a lot of clinical trials where, and you start to look around the sodium world, there's a lot of broad error bars, but like anything else like NT-proBNP or even EGFRs, where the error bars do overlap, and that's okay. There's broad variability in the number of the type of patients we had come into the trial. So that's actually, in some respects, makes them more robust because we have a broad set of patients who came in, not just a narrow band of people only eating a certain amount of sodium per day, but they do overlap. And so the difference between the way we've done it in a number of different ways, if it's an ANOVA or an ANCOVA, we've done it in a whole bunch of ways to make sure we're not missing some of that variability that would miss the difference or nullify that difference. But it's a fair point. The nice part is, and even in the review process, we pre-planned after the primary publication to do some looks at the differences between where people start. So 3,000 milligrams per day or more, 15 to 3,000. And really, there wasn't much of a difference in the clinical outcomes, but we really have to look at that in a much more linear fashion. And that's one of our planned analyses, to look in a much greater, finer detail, because those error bars do overlap. So maybe there's a signal that's hidden in there that we need to really unpack.
And so let me ask you another question. We were wondering, did you perceive any difference in blood pressure? Because as usual, we're treating patients with sodium depleting drugs called diuretics, and there should be some kind of effect on when you change the sodium intake on the blood pressure. So
we tracked it because that was something that we kind of predetermined. A priori hypothesis is that it may change it.
Yeah.
And so we tracked it in every clinic visit, and we saw that that figure where it's not statistically significant, but in the first 3 to 6 months, is there a difference? Is there not? Those are differences of like 1 or 2 millimeters of mercury, and not with a huge overlap of those error bars. So I am not convinced that there's an actual difference. And in fact, I think once we move away from the prevention stage of like hypertension, where it probably does make a bigger difference. That's what Bruce Neal was trying to show in the SAS trial, is effectively, if you just change that, it changes blood pressure, which changes the outcome. I think once you get into the population of patients with, end-stage kidney disease, heart failure, there's less of a difference in blood pressure based on that. In fact, it may not have any difference in blood pressure, which is what we were showing. Doesn't look like there's much of a difference. And the corollary of this is, in some of our trials using spironolactone, for example, the blood pressure doesn't go down in our patients. It probably stays neutral, and it may actually, completely conversely go up in a couple of patients. And why is that? It doesn't make sense, but our patient population is so different from what the hypertension population, which is often where we draw our assessments from.
And last question. Did you see any adverse effects in the interventional group?
Yeah, so we were very pragmatic. We didn't see any, and we actually asked sites to report specifically on that, and there were none. I mean, the irony is, the last time you went out for a burger or a salad, can you remember any adverse events from it? And it turns out it's really hard to assess any causality there because, you know, it is diet and people are changing their food products. So it's not surprisingly there were none reported, and I don't think we would anticipate there was any. None of the ethics boards or regulatory bodies required us to actually even capture or report them, but we didn't see any either way.
So thank you. So those were my questions.
I would like to hear now the ideas of our second expert, who also did a randomized trial. And yeah, it's again a pleasure to have Professor Beck-da-Silva with us.
Thank you, Dr. Heine. It's my pleasure to be here and to have the opportunity to make questions in person with Dr. Ezekowitz. My main concern about this trial is that as he had confessed right now that his objective was to have 500 milligrams of sodium of difference between groups. So in fact, what they really could get during the trial was very close to what the intention was, which is good. But my concern is, and my question is, why did you had this such a small difference as an objective? And wasn't you concerned at the beginning that this could be a beta error in the trial?
Well, no, it's a great question. It's one that you know, I think will plague the interpretation of this trial for all of time, because we had to set a level to target, and that was 1,500 milligrams. And what we quickly realized, when you look at the population of heart failure patients with heart failure that we had data on, their food records indicated about 2,300 to 2,400, maybe 2,500 milligrams per day. So what we thought was, do we target getting 1,000 or less, like a real big difference? And I thought from a pragmatic perspective, if you ask me to reduce the dietary sodium in my diet by that amount, it's going to be hard, and I'm not sure achievable. And so we accepted that we'd shoot for a threshold, which was the less than 1,500. And for most patients, that would be about 500 milligrams a day. Now, there are patients in there, as you identify, that we're starting off at probably 3,000, 3,500. And so for them, that difference or that drop or that delta is going to be much greater. And so the trial might have looked a bit different if we had done that. Now, the counter to that is these two pilot trials that were targeting people with a 3,000 milligrams or greater, and they reduced to 3,000 versus 1,500. There's no difference in clinical outcome. Very short-term trial done in the southern US, no difference in outcomes. But so those are the very high users to a very low level, and they didn't have any NT-proBNP differences, any quality of life differences. And so, you know, maybe our hypothesis is wrong, and maybe it's not the level, maybe it's the patient individual factors that may be playing a role. And Dr. Beck-da-Silva, you've done a trial in this area. You know, what are your thoughts on the same topic?
Yeah, great. Well, that information about the 3,000 is very good. I didn't know that. But the thing that we are seeing, and we are all learning with all this research, your research and others, is that really maybe the salt restriction in our patients in a contemporary treatment of heart failure, which is completely different from the 80s, we are seeing a change in all the physiopathology of heart failure, and in a sense that maybe having some quantity of salt may be a good thing, not a bad thing. And for instance, we see that everything that stimulates the angiotensin-renin system in heart failure is bad, and everything that blocks that system seems to be good. And we have those papers showing that if we promote salt restriction, actually we start to produce more renin and angiotensin, and that curve in your death graphic showing a kind of a trend that maybe doing restriction might be worse. It's very concerning, because there might be some truth on that figure, right? We have recently published a meta-analysis of salt restriction, and we have seen some harm with the salt restriction. So maybe we are changing from one side to another, and I'm really it's difficult to recommend nowadays what we should do. Because you have your trial, we have all this information available right now. We see the guidelines that everyone teaches one thing different. If you get the American, European, Australian, Brazilian guidelines, they seem all to be different. So we need the guidance on that subject. And I'm concerned that maybe if our patients are well treated, maybe they don't need to take much care about the salt restriction.
Yeah, I do think that's a fair point, that the modern era of therapy is night and day compared to, say, 1980s, and so it does change that paradigm of what the pathophysiology underlying those patients' issues are. And to amplify that one step further is that when we start to think about any dietary modification we make can adversely affect their ability to take in the right amount of calories or other nutritious products. So you can actually have a knock-on effect that could be amplifying those. And when we take that even one step further, we have to recommend, and as a nephrologist, you'd probably be doing this every day, Martin, but is a low potassium diet. And that's actually all the things I like to eat are high in potassium. It's the fruits, the vegetables, all those things. And our patients have to suddenly restrict on all corners. And so we are not dealing with a 1980s physiology, we're dealing with a modern day physiology. So how do we control those things and help our patients so they can eat a healthy, nutritious diet? And I'm not certain we have it right either, Dr. Beck-da-Silva.
Yeah, agree. And this is a really point that, I mean, the heart failure experts around the world have to convey this message, because what the general physician is really still doing is to recommending salt restrictions to everyone, right? And again, another thing that is very important to highlight is hypertension is different from heart failure, right? Of course, we are not here recommending huge amounts of salt to the population. No, that's not true. We are just, as soon as you have a heart failure condition and you are well treated with the contemporary treatment, maybe, and even after you are taking diuretics, as you said, it's a different scenario. And maybe even for our diuretics to work, we need a little bit of salt to give them substrates for the nephrons to work.
Yeah, so maybe one comment on that too is Dr. Beck-da-Silva, is we all have our set of patients who they go out for a very delightful meal that is high in salt, and so they say, oh, I kind of know, I can see my swelling at the end of that day or the next morning. So that's that group of patients over there, and then there's those who it doesn't seem to affect. And so I think we lump them all together and give the general advice, and it's clearly not the right way to do it. So I think we do need to be circumspect on some of our patients who say, every time I have that large, let's say Chinese meal or big, I don't know, big German sausage at the beer fest, anything that could be happening, any Brazilian meal, basically. Barbecue, that they are those patients who are sensitive, and we need to treat them differently from those patients who seemingly are untouched or unscathed by that meal. That's
possibly true as well. Yeah.
There must be some lower limit below which there's an increase in risk. It's, I guess, somewhat comparable with blood pressure or blood sugar or something like that. So if it goes to 0, it shouldn't work. And this kind of differs from cholesterol or smoking, where we would really advocate to go down to 0. If I'm correctly informed, there were even some Italian groups that kind of propose the opposite and do studies in heart failure and giving these patients high dosages of sodium in order to treat them in their decompensation, if I got it right.
Yeah, there's a few trials with using hypertonic sodium saline solutions. It's usually about 3% or so. these small boluses as a means by which people can be effectively diuresed. And there's actually an ongoing trial testing this again. I think those earlier trials unfortunately combined it with 2 other interventions, such as a low sodium diet and severe fluid restriction, which I think is problematic. But it's certainly an area because there are some good physiologic rationales to why that might be more effective in getting patients excess fluid off. I'm not a big proponent of it as a first-line agent, but it's certainly something we would reach for if we're struggling with a patient and individual. So I think that the trials need to be done in a very more isolated way as just that thing, not the fluid restriction plus the salt restriction, which to me, if you put those things together, you're not answering the question we were set out to answer.
And plus the hypertonic saline is another patient, right? It's that particular patient that's very hard to diurese them. That patient really, you are having a hard time to treat in the hospital. It's a complicated patient, but we have been used that here, and we have had a bit of success using hypertonic saline, but it's hard to compare with the patient in the ambulatory setting, or even in the inpatients that are not a C hemodynamic profile, right? It's usually most of the patients are in the profile B, like they are just congested, and maybe it doesn't really matter how much salt they eat. That's my impression nowadays.
So if I got it right, the study is still ongoing and you are still collecting 2-year and 3-year data. Will you try to keep the 2 patient groups divided with regard to their sodium intake, or is the active study phase now over and they are just free to use whatever diet they choose for?
Yeah, so the active part is over at the end of the 12 months. We just had no resources to continue that phase of it, but we have the data for many of our patients already past 2 years, and we'll get out to 5 years. One of the interesting parts is because we have a substantial number of patients who have just hit the 2-year mark already, we can start to dive into that data. But also the non-cardiovascular hospitalizations and ER visits, that's a grid of information we want to get into. The other tiny part of that, which is really fascinating, is in the dietary world, that most people, once they've changed their diet after 6 or 12 months, they tend to stick to it. And so while we can't be 100% certain that their arms will remain separate as they were randomized, this will be all post hoc about us making a little bit of a squinty eye to say it's probably right, but we will actually have a sense of those 2 arms if they still remain separate as to where they started. So the dietitians say, well, once they've got to 12 months, they're eating that, they're kind of fixed in time. They're going to keep going, that diet. And I say that's probably true, probably not for all patients though.
And I have one more question with regard again to clinical practice. So do you do in your clinical practice 24-hour urine collections? Because we do quite often, even in patients who are on diuretics, because I kind of believe that someday, even if they are on a diuretic, there should be some stable phase when actually those who have a high intake are also prone to excrete more sodium. Do you do this in clinical practice for kind of managing your patients?
So I generally don't, and I'll tell you, generally they're hard to do, and I often wonder about the value we're getting from that information. So it's not that they're not an accurate assessment. I don't need them for my practice, but for any of our patients we share, like with our nephrologists, it's often done for things like protein, all the other questions that need to be answered. But that's not something that I do just specifically for sodium. In the acute setting, I do like this new approach, newer or redux of an old process of testing urinary sodium in the acute setting, where it can actually give us some early guidance in the 4-6 hour mark. And I think that's actually quite useful, the spot urine sodium. It's not perfect, but it's a rough guide, like a big fence. It's a big sign on the road, like this is good, that's bad. That's about all you get out of it. And that's actually sometimes all we need in the diuresis phase.
So as kidney doctors, we are surely obliged to do some collection from time to time to really convince our patients that their sodium intake is much higher than their general estimate. So as Martin Brzoska said, at least here in Germany, with all our sausages and stuff like that, they are way above 3 or 4 or whatever grams of sodium. And if they do the 24-hour collections, and if I can tell them afterwards, well, we found 7 or 8 or 9 or whatever grams of sodium, then they are really kind of convinced that they should change their diet in a particular way. Huh?
Yeah, and I think that's the key, is as you've got a different population, and I think the nephrology community has done a great job of trying to understand it, and we're just catching up. And I always rely on my nephrology colleagues when there's tricky questions, because they're always smarter. So I tend to lean into them when we have questions around anything about urinary electrolytes, anything around which section of the nephrons being affected by the thing we're doing.
So this sounds like a perfect final word, actually, to learn that the kidney doctors are the smarter ones. Thanks so much for being our guest. It was really a pleasure to have all of you and to discuss this issue. And we are looking forward to reading the 2-year, 3-year, 4-year maybe data in order to see really the long-term effect of your study, which is so important. Thanks so much. Have a nice morning, both in Canada and Brazil. And thanks a lot.
Thank you very much.